Hey everybody, Chris Hammond here again. Thanks for joining me for the next medical director training. Today we're going to talk about some of the why behind ACLS and reasons that we tend to do some of our protocols and what we're doing. Not all of it jives with our exact protocol, and it's some things to think about, and maybe some things that will change in the future, but it's a bunch of studies that really kind of talk about what's behind the reasons we do ACLS and resuscitation the way that we do it here in Los Alamos, which is often different from a lot of other places. Just a few notes. This lecture is pretty long. I made it a few years ago. I'm shooting for about an hour, so I'm going to try to narrow that down and try to keep this to maybe 45 minutes. 40 is kind of what I'm shooting for. I didn't get any questions from the last hyperkalemia lecture, so if you have those, get those over to Captain Pacheco, and he'll forward them on to me, and I'll address them next month. Same with any questions in this month's education as well. We've had a couple cardiac arrests in the last few months, so I thought this was kind of pertinent to talk about. And you'll see this is pulling a bunch of studies and data out of 2000. Like some of the stuff's early as 2001 up to 2014, 15 kind of time frame. Some of the newer, there is definitely some newer stuff out there, but not a lot has changed in the last couple of years that compared to what we're doing, actively now. So yeah, let's get started because this can be a little long. Let me share my screen with you, and we'll get going here. All right, so here's some basic objectives, whatever, we'll go through all of this. So where are we in terms of just out of hospital cardiac arrest and patients actually surviving? If you look at kind of this graph, the data, 2006 here at the bottom to 2010, top line is VFib arrest or VTAC arrests with bystander CPR. The red line is VFib, VTAC without bystander CPR. Green line is just EMS treatment. Dark blue line is PEA, and the bottom line is asystole. So as you can imagine, witnessed cardiac arrest with bystander CPR found in VFib or VTAC is your best outcome. 2006, 2010, we're running 25 to 30% for survivability. This says nothing about neurological outcomes and function as they leave the hospital. But just in general, survivability in our best case scenario can be upwards of 30%. When they're found down and you show up and start CPR, or they're in PEA when you get there, much lower, somewhere in the 6 to maybe 10% range or so. Looking at a great looking EKG, right? Initially, this kind of looks like VTAC, but it's certainly not fast enough to be VTAC. So if you take this line, go to the next one is 300, 150, 100, 75. So the rate's somewhere around 80-ish. So can't be VTAC if it's 80. It's got to be greater than 120. You'll see these big ST segment depressions in 1 and AVL, big depressions over here in V2, V3 a little bit, but then these are just monster elevations in 2, 3 AVF, and then in these kind of lateral precordial leads as well, which precipitates into this kind of rhythm. All right, so we find this, whether it's VFib, VTAC, or polymorphic VTAC or something like that, this is your patient. So what do we do? Let's start. We'll go through, talk about airway, breathing, circulation, and some of the studies behind all this. So here's your options with airway. Intubate them right away, and non-rebreather, you can throw in your LMA or your King airway, BVM only, hands only, or putting them on a ventilator. All kinds of options to do, and we'll talk about which ones seem to be the most beneficial for patient outcomes. You know what those are. So here's a big study, 2010, looked at advanced airways and what was again, this is about survivability right now, not neurologic survivability, but just survivability. Where I want you to focus here is really BVM versus endotracheal tube. I'm not a big research guy that talks about confidence intervals and regression analysis, but basically what they found in these two variations that they were studying is that the intervals of patients that survived with a use of a BVM only versus an endotracheal intubation was higher in both cases of BVM use and not endotracheal intubation. Lots of other variables that considered in this thing, but that was where I focused on this. Same thing in this study. It was intubation versus not intubating to survivability was better with not, with BVM and not an endotracheal intubation. What's the whole point? Like, why does that matter? Really what it comes down to is, as a paramedic, when you intubate or when I'm in the hospital intubating, some of it's quick and easy, but it is a lot harder to intubate a patient correctly and to verify, tube placement and seat cords when somebody's jumping up and down on their chest. So when I first started, I always told everybody stop compressions because I'm intubating. Seems to be the very wrong thing to do. So here's why though. So if we look at just a graph of time versus perfusion pressure, and perfusion pressure we're talking about is coronary perfusion pressure. So CPP is often how it's referred to. Coronary perfusion pressure takes time to build. So as you do CPR, you build this coronary perfusion pressure. So let's say we've got 2 minutes of CPR here and we stop because we want to intubate the patient. Our coronary perfusion pressure goes back to 0 basically, and it takes 10 to 15 chest compressions to get that perfusion back up again. And so this is really where the damage occurs in cardiopulmonary resuscitation, is when we're not perfusing the blood vessels which supply the perfusion to the heart, which we're trying to get restarted again. So if we associate that with neurologic outcomes in out-of-hospital cardiac arrest, looking again, here's your graph on BVM use versus endotracheal intubation and several different studies and a handful more. All of the studies favored BVM use for ventilation versus endotracheal intubation in terms of neurologic outcome, right? So these are the people who not only just survive, but the patients who walk out of the hospital neurologically intact. The patients who do that are often only treated with the BVM until they obtain ROSC or something like that. And we'll talk more about that down the line. But BVM use or uninterrupted, I think in our protocol, uninterrupted supraglottic airway, like the King airway being placed, is certainly adequate, but something along the lines that's not going to interrupt CPR and adversely affect our coronary perfusion pressure. A couple of interesting things with respirations. We're going to talk about the number of respirations and why we do, 6, 8, 10, 12, and not 30 respirations a minute in cardiac arrest. But I thought this was interesting, and for our dispatchers could be interesting as well as some of the information that you can obtain prior to arrival. Looking at incidents of agonal respirations in cardiac arrest, you read, sorry, this thing keeps showing up. If you read just this conclusion part, it says there's a higher incidence of agonal activity associated with out-of-hospital cardiac arrest, and the presence of agonal respirations was associated with increased survival. What does that mean for us? Probably not a whole lot. You're going to do the same thing, but if you arrive on a patient who's got agonal respirations, the chances of them surviving their cardiac arrest are higher than those who do not have agonal respirations. Same thing in another study here, looking at pre-hospital stuff. There says there was a positive association between the presence of gasping and survival. 28% of the patients who gasped survived, with 8% of those who did not gasp. And this was out of 481 patients who received bystander CPR and survived to hospital discharge. And it was 39% of the patients who gasped survived, and 9% of those who did not gasp survived. So just something to think about when you get on scene and the patient's got agonal respirations. Probably a very good prognostic indicator for survivability. If we look at the respirations of why we do, somewhere between 8 and 12 respirations a minute. They did a study on, this one is on, I think this is pigs. If you do, if you can measure systolic blood pressure, CPP is coronary perfusion pressure. Obviously, we don't measure that in patients who we're trying to resuscitate. And then mean intrathoracic pressure, basically the pressure in the chest that would impede your hemodynamics to some degree, right? So systolic blood pressure at a respiration of 12, we've got a number at 68, their CPP of 23, and their mean intrathoracic pressure is low at 7. So as you increase your number of ventilations in their respiratory rate, obviously their intrathoracic pressure rises, their CPP then conversely goes down, as well as their systolic blood pressure. We can look at, in this same study, they looked at pH and how their pH is affected by hyperventilation versus normal ventilation. But really what I'm after is overventilating a patient. You're going to raise intrathoracic pressure, and higher intrathoracic pressures adversely affect your systolic blood pressure and your coronary perfusion pressure. So if you look at a rate of 30, we have no basically survival down here, and even more, but somewhere around this 10 to 12 number is really where the bell-shaped curve was in the positive and then sloped down, continuing to decrease as you increase the number of ventilations they got per minute. We're not using ventilators here for the most part, and I think we used it in our last cardiac arrest briefly. But how do you set up your ventilator, right? So respiratory rate of 10 to 12 with a volume, it's easy to pick somewhere between 400 to 500. That fits for most people. I guess metric to use for this is the lung protective tidal volume level, and that's going to be 6 milliliters per kilogram of ideal body weight. So you can look up, get an average estimate of their height, their ideal body weight, and then times it by 6. For most average people, again, it's going to be in this 400 to 500 range. 100% FiO2 until they get ROSC. That's probably not your job to decrease their FiO2 on your transport in, because you're focused on a lot of other things. But in the ICU, that's what we'll do is decrease their FiO2. Is being able to do that is associated with better outcomes as well. Circulation. So this is really where we get to the meat of this. So this is kind of fun. We talk about ACLS with H's and T's, right? Everybody's always doing the class, and do you remember your H's and T's? This is a much better kind of simplified version of that. So if you've got PEA, there's two types of PEA, narrow complex and wide complex PEA. So narrow complex usually tells me there's something, the way I think about it is there's something that we're going to have to do, whereas a wide complex PEA usually means there's something we're going to have to give. And I'll show you what I mean by that. Narrow complex PEAs are associated with cardiac tamponade, tension pneumos, hyperventilation with crazy intrathoracic pressures, a pulmonary embolism. So these are all impeding things on your kind of ability for your vascular to fill or empty one way or another. Wide complex QRS PEAs are associated more with metabolic things. So whether it's their flecainide, sodium channel blockers are going to be some of your cardiac meds, your flecainide, procainamide, things, not super common drugs, but some of the drugs that are out there if people have a cardiac history, and hyperkalemia, which we probably don't see a whole lot, like we talked about last month, but that's going to be most commonly in our diabetics on dialysis. So here's how I kind of see this narrow complex QRS in PEA. Here's your kind of several causes: cardiac tamponade, do a pericardiocentesis, tension pneumo, certainly in the setting of an arrest with chest trauma. This is probably your biggest thing why they're in PEA in your traumatic patients. Usually some kind of ventilation management problem, and the other one that we never are able to explain why people die is probably the pulmonary embolism. And that one, just like an MI in the setting of an arrest, gets thrombolytics by us in the hospital. Wide complex PEA. Here's your severe hyperkalemia, like we talked about. We're going to give chloride, calcium chloride, calcium gluconate. We're going to carry calcium gluconate because we can push it IV. But this is where that comes into play. And then your sodium channel blockers, you're going to give sodium bicarb, which I think in our last guy, I can't remember if he was on a sodium channel blocker, but certainly responded very well to sodium bicarb. Let's look at, so this is I thought this was interesting because I know we have these Lucas devices or whatever, automated CPR assistants, I guess I would call them. So this one looked at use of the Lucas device versus manual CPR. Every study that they did basically favors manual CPR over mechanical CPR. There are two incidences that I think that it's beneficial to use the Lucas device. Probably the first one is in the cardiac cath lab. Really hard to do CPR on a patient at the same time that you're trying to thread a wire and stents through their radial artery and open up their cardiac vessels again. So the Lucas has definitely a play there. And that doesn't happen here very often, but our long transports. When I was in residency, there were units that had 45, 50-minute transport times to the hospital, and that's a long time to do CPR. So I think those are probably the two indications to use that device. Everything else really in the real world favors us using our hands and doing manual CPR. So cardiopulmonary resuscitation quality, how are we improving some of these in both in and out of the hospital? Again, these were the metrics that came up. We're already ahead of the curve here, right? This is what we're doing. So your hands-on CPR, where you're doing chest compressions greater than 80% of the time of the resuscitation, your compression rate is going to be 100 to 120 compressions a minute at a depth of 50 millimeters or 2.5 inches, something like that, and avoiding excessive ventilation. And we're going to look at a few of these studies as well. So in studying this, there's a few things that we can look at in the field. Right? We're not measuring CPP, right? In the ICU, we're not measuring CPP. This is mostly done in animal studies. Arterial blood pressures, we can monitor pretty closely in the hospital, but capnography is really where your main information is going to come from on the quality of your resuscitation. So end-tidal CO2 greater than 20, and we'll look at a study that says, if you're greater than 25 for a sustained period of time, what's the chances of their survivability? And then here's what, basically adversely affects all of these is when we're not doing chest compressions and we have interruptions. So there are some things that are reasonable to stop chest compressions. Right, when you change, the guy who's doing chest compressions, that's certainly a time you have to stop, but the minimal amount of time, and you guys are really good at that. Any kind of transport thing, if there's trauma with backboard or stabilization, you're going to have some time off of the chest. Defibrillation is a very quick time off the chest. Probably rhythm analysis is where we probably spend most of our time not doing CPR resuscitations. And we'll look at some of these other things as well. This was a study that basically looked at why do we get right back on the chest after we administer defibrillation on a patient. And it showed basically this was a study of 157 patients or something that all of them sustained some time frame of asystole after defibrillation. And this is time in seconds, basically extending from 1 second up to 60 seconds for most of them, and the longest one was something crazy like 8 minutes of asystole. It must have been in an animal study or something. But basically, it's saying in your defibrillated patients from VFib or VTAC, the reason you get back on their chest is because they go into asystole, and a prolonged asystole is then going to lead to PEA, continued asystole, VFib or VTAC again, and so this is why we start compressions immediately after defibrillation. This one is adverse hemodynamic effects of interrupting chest compressions with rescue breathing in your VTAC patients. And again, this goes back to coronary perfusion pressure, right? So if we did that whole thing we used to do however many years ago of the 15 to 2, every time you stop your chest compressions, your coronary perfusion pressure drops back to 0, and you've got to build it up over time. This is what we're doing now, right? With sustained coronary perfusion pressure over the long term of the 200 compressions, the 2 minutes, something like that. So why in the world do we even pick, 100 to 120 chest compressions a minute? Came down to, these multiple studies that basically in a bell-shaped curve, if you do 50 chest compressions to 160 chest compressions, what does that look like? It really is just a bell-shaped curve. The more chest compressions up to about 110, 120 gave the highest survivability in these studies versus as you get higher in your rates, your survivability goes down. This one was a weird study. I honestly don't remember what this was. This was measuring, I think this is measuring something very different, but this is kind of the general trend of what survivability looked like in chest compressions and why the rate that we choose. Yeah, again, this is all about minimizing the time that we are interrupting our chest compressions. And basically just says interruptions in precordial compressions for rhythm analysis that exceed more than 15 seconds before a shock or compromise your outcome of CPR. Again, that's we're going to look at kind of what you guys do and how we do it faster rather than kind of the old way of CPR, stopping for a rhythm check, charging the machine, defibbing them, and no CPR is done for 2 or 3 minutes or something, it seems like. Survival from, this was a canine study where they, dogs had a very long cardiac arrest time, or I should say prolonged cardiac arrest time, looking at their coronary perfusion pressures. And when they measured them in the lab, if you could sustain their coronary perfusion pressures greater than 25, the survivability at 24 hours was much greater than sustained pressures at 15 or sustained pressures somewhere between 5 and 10. So this is what we're after. Again, we can't measure that. Some of the implications of that is the end tidal CO2 being greater than 20 to 25. But this is what we're after, is prolonged coronary perfusion pressure above 25, basically. Another one in a swine study that said the same thing. Here's top line is swines that obtained ROSC. The bottom line is ones that did not. And again, they couldn't get their coronary perfusion pressures greater than 20, and survivability of these ones was much higher when their coronary perfusion pressures was greater than 20. More hemodynamic monitoring. So just other things, all kind of theoretical for us, but in the lab, this is different ways to look at it. Coronary perfusion pressure, again, over time, top line is survivors, bottom line is non-survivors. So again, a low coronary perfusion pressure is going to is not compatible with survivability. Higher coronary perfusion pressures lead to higher survival rates. And here's the numbers in this study, looking at less than 15 millimeters of mercury or whatever they're measuring it in patients that obtained ROSC. 0% obtained it. 46% obtained it in this 15 to 25, and greater than 25 for your coronary perfusion pressure led to 79% of patients obtaining ROSC. So it doesn't matter if you get the heart started and it works and you're a vegetable laying in bed for 4 years on a trach and peg tube and all that stuff. What ends up mattering in the end is your neurological outcome. So really, though we talk about coronary perfusion pressure, the other side to that is cerebral perfusion pressure, which is also CPP. And that's what we're in the end, we're really after here. There's another study doing the same thing, right? Measuring coronary perfusion pressure with CPR and the neurological outcome of these cardiac arrest animals. Some of that's associated with arterial blood pressure and specifically diastolic arterial blood pressure. This is another one, just kind of same kind of concept. Is after perfusing the brain more than perfusing anything else. So cerebral perfusion pressures, improving neurological outcomes. Down here it says, in adult patients with witnessed cardiac arrest and the initial shockable rhythm, implementation of an out-of-hospital treated protocol based on principles of cardiocerebral resuscitation was associated with dramatic improvement in neurological outcomes. What does all that mean? It's what we're doing here in Los Alamos, and I'll show you already. It's the minimally interrupted CPR, the correct number of chest compressions, and the correct ventilation and proper defibrillation and timing of defibrillation. So this is what you do, right? You show up and you start chest compressions, 200 chest compressions. You do an analysis, shock if appropriate, back on the chest, administer your epi with a, get a line while this is first happening. Continue to do CPR, administer your epi, antiarrhythmics if appropriate, and shock if, in a shockable rhythm. This is old to us now. I think that's just kind of common knowledge of what we're doing. This is not common knowledge everywhere and what everybody's doing, by the way. Same kind of thing, just looking at a different chart. So why does all that matter? These got into a little more, deeper hemodynamic monitoring, where they're looking at aortic diastolic pressure, aortic systolic pressure, and right atrial diastolic pressure. Basically, again, about what's the heart output instead of the coronary perfusion pressure. What was the output of the heart? And so blood pressure 125 with the aortic diastolic down here, aortic systolic. So again, this is time and continuous chest compressions. What does that look like over time? And again, just like the coronary perfusion pressure, the aortic pressure, the perfusion pressure to the brain coming from the aorta is higher as we have continuous CPR that's uninterrupted. Outcomes. Oh, this is, again, talking about how do you minimize the interrupted time when you're required to do defibrillation. And I think we do that as well. There's another chart here I like to show you. So this is what we used to do, right? We do CPR, we stop, we analyze their rhythm. If it's shockable, we then charge the machine, we then shock them, and then start CPR again, right? So the total hands-off time is this whole duration here. The next best way to do it was we do CPR, we analyze, we continue to do CPR while the defibrillator is charging, and then we shock them. Where this is what I'm sure we're doing here, and certainly what we do in the hospital is you do chest compressions, charge the machine, analyze the rhythm, and if a shockable rhythm, then we administer the shock, and then right back on the chest. This one gives you clearly the shortest duration and single time that you have interrupted CPR. Talks about vasopressors and why do we do epinephrine. Turns out no great benefit to giving any kind of, any of these drugs, though they're, they pimp you significantly on ACLS about all these drugs. Turns out, right, we're going to give it because that's what we have the ability to give, but it never really changed the the neurologic survivability outcomes. It definitely gives some short-term benefit and boosts the heart, and we get them to the hospital and they're alive. Their long-term survivability and neurological outcome was never been changed by the administration of any of these drugs that we do. If we are going to give it, there's a study that basically said the sooner you give epinephrine in an out-of-hospital cardiac arrest, their outcomes are better. And so it looked at not just giving it yes or no, but the timing of giving it, adding it early on, which is what we do as well, right? So you're doing your 200 chest compressions and somebody's getting an IV, and as soon as you have access, now we're giving this. That's not as interesting. There's this cardio, we talk about, causes of death, and MI is probably the most common one that causes VFib or VTAC, but the one that causes PEA is probably always their pulmonary embolism. Not much you're going to do in the field, but something to consider for thrombolytics when we get to the hospital. This is an interesting study that talks about how do you minimize the amount of time that you are off of the chest during defibrillation. and it looks at the amount of this is the amount of joules 0 through 10 delivered to the person doing CPR at the time of defibrillation. It turns out there's probably, 6 to 7 joules that can be transmitted across the what do you call this person? We'll call him the CPR person, and kind of dissipates over the course of their body to become less than 1 joule in their shoulders and hands and things like that. So I'm not saying that you should keep your hands on their chest while you're doing CPR, but there are definitely some studies out there that say that there is minimal amount of joules received by the rescuer during defibrillation during CPR. I also think it's a very quick thing, and maybe we just need to debunk it and have people get shocked to figure it out, but I'm not advising that from our crew. But there are definitely some studies of people who just do it and have no adverse effect from this. One day somebody will, and they'll tell everybody not to do it, but I think you can have minimal time off of the chest just by lifting your hands a few inches, shock, get back on the chest right away. I think it's a minimal amount of time we're losing coronary perfusion pressure. This just gets into the fun stuff of when stuff doesn't actually work. So what happens when they're in VFib and it's refractory, right? So you shock them at 360 joules and do CPR, and your next rhythm check, they're back in VFib again. You shock them again and back on CPR, and they're still in VFib. So what do you do with these patients? A couple ways to manage this. This is an interesting one. I'll tell you about the one that I actually would do before I do this, but this was about a sequence external defibrillator where you just have another unit, you put 2 more pads on them, and you sequentially defibrillate the patient with 2 units at 360 joules. And its effect basically in treating refractory VFib was fairly significant. It says that the importance of an additional defibrillator being readily available. The technique is rapid, double sequential external shocks may have general applicability, providing a simple and potential life-threatening approach. So in their study, there was like 5 patients or something that had refractory VFib, and I think 4 of them were converted out of it after sequential VFib or sequential defibrillation. Another study, same thing. So sequential external defibrillation with 10 patients, and this was, let's see, refractory RVF, refractory VFib was terminated in 70%. So 7 of the 10 cases were treated with sequential defibrillation and converted out of their VFib. Turns out that none of them survived anyway. So why does the patient go into refractory VFib? So they talk about this being some kind of an electrical storm based on basically your sympathetic nervous system. So if you think about it coming as a sympathetic response, how do we treat that normally, right? So normally it's benzos on your overly meth high patient. You're going to treat it with benzos. From the electrical side of things, in a patient with refractory VFib, you just give them a beta. So ethanol, propranolol, gonna give them a beta blockade. So this study looked at treating refractory VFib with sequential 2 defibrillations. They treated them with beta blockers. 7 of the patients got esmolol, 14 of the patients got propranolol, and 6 got this left stellate ganglionic blockade. I'm not exactly sure what that is. In the end, it says the 1-week mortality rate was higher in group 2, which was the group that was treated with only ACLS guidelines. And 18 of their 22 patients died, all of refractory VFib. 6 of the patients in group 1 out of 27 died. What does that say? I'm sorry. 6 of the 27 in group 1 patients died, 3 of them from refractory VFib, versus 18 of 22 that died of refractory VFib in the other group. So looked like this is something promising, right, to treat with some kind of beta blockade. Another study, again, supportive of treating with esmolol, beta blocker, in refractory VFib cases. I forget, the numbers are down here, but it was substantially different. So 67% and 32% had sustained ROS, 66 and 32 survived in the intensive care unit, 50% and 16% survived a hospital discharge. So this higher number is the patients who receive esmolol, lower number is the patients who receive ACLS treatment solely, which they're getting amiodarone or lidocaine or something like that. So interesting data for certainly in the hospital side. We're going to start pushing esmolol in the field with our transport times. Probably not going to something that we're going to start, but something to think about. If you've shocked them 3 times by the time you get here, that's where my mind needs to go, is to start treatment. Back to something that's really mattered for you guys. So this whole thought of end-tidal CO2 and how it really gives you a prognostic indicator for survival. So end-tidal CO2 and outcome of out-of-hospital cardiac arrest. So there's a number of patients, basically, number of patients over patients who died outside the hospital and patients who survived to hospital admission. Again, probably doesn't say anything about neurological outcomes, but just really survived to the hospital. So end-tidal CO2 is less than 10. Nobody survives, right? You start getting in the 20, 25, 30 range. This is where survivability occurs. So you're seeing these numbers. Chances of survival are much higher and tends to be the ones we work longer because of their higher end-tidal CO2. Definitely work these ones shorter. So when you're talking about calling somebody in the field and their end-tidals are in the 30s or 40s, it's something to just think twice about, and not saying that it's wrong. It's just something that we're going to start thinking, just to have you think about this end-tidal and their chances of survivability. Another study, same thing. Patients with ROSC after CPR have statistically higher levels of end-tidal CO2. The average end-tidal CO2 level of 25 in participants with ROSC is notably higher than the threshold of 10 to 20 to improve delivery of chest compression. So you can evaluate how good your chest compressions are in most patients on your end-tidal CO2. This goes on more to hospital management, kind of where my thought process is when you bring in a cardiac arrest that's resuscitated, or we resuscitate them here. Looked at basically which patients need to go for cardiac catheterization, and unless you find another cause of why they arrested, whether it's their respiratory distress or something, even if they have a normal EKG, should they go to the cath lab and be transferred out of here? Turns out the answer is probably yes. Sorry, looking for it here. Yeah, so basically, any of these patients who have cardiac arrest for an unknown reason, which most of them are, they didn't arrest because they're COPD and they've been breathing hard for 5 days and refused to come to the hospital, but really just kind of drop. We had a guy who was in VFib several months ago in this same picture, and most of the time it's going to be associated with STEMI or something, even if their EKG is normal. Anytime you pick up somebody from a gym who is in cardiac arrest, you assume they've had a STEMI. It says out of hospital cardiac arrest during exercise was associated with significantly lower mortality in successfully resuscitated patients, even after adjusting for confounding factors, because acute coronary syndrome was most often among exercise-related cardiac arrest patients. So ACS, or acute coronary syndrome, is basically your precursor to having an MI. So anytime you pick up somebody from a gym in cardiac arrest, like they've got it, they're going to end up going to the cath lab 100%. Again, bunch of studies from 2007, 2013, looking at which cardiac arrest does it favor cardiac catheterization post-arrest once they've obtained ROSC, or is there conservative measures rather than a more aggressive measures? Every study, I think minus that one on the halfway point, actually all favor that they get cardiac catheterization. So my thought process is in any resuscitated arrest, they're going to go be transferred and need a heart cath. Whether or not they get one, it's not up to me. Again, another study, it says early cardiac catheterization is associated with improved survival in comatose survivors of cardiac arrest without STEMI. So just because their EKG doesn't show a STEMI when we resuscitate them doesn't mean they don't need a heart catheterization. Same kind of thing. And then they start talking about hypothermia. Hypothermia is a kind of a questionable piece. We overshot the mark 10 years ago, and we're cooling everybody to 32 degrees or something. Most intensivists really have landed in the area of around 36 degrees Celsius. So a few degrees cooler than your normal body temperature seems to be a positive association with neurologic outcome. So summary, post-arrest stuff, this is more for me, right? So when do you kind of call it and what do you do in the ICU? Again, more of some of the prognostic indicators in the ICU is if they have a corneal reflex or a pupillary reflex or response, kind of your obvious things of who's going to have a good outcome. Some of your bad things in the field is if we've been working this code for more than 30 minutes, the chances of their survivability neurologically is going to be extremely low. If they've had no CPR for more than 8 minutes, expect a very poor neurological outcome for sure. Seizure type stuff is what they're looking at here in the ICU, as well as a bad prognosis. Good prognostic indicators, you start getting reflexes back within 48 hours. You've got some purposeful movement in 24 hours. The obvious things that we think you could tell are probably good indicators. So a couple takeaway points here. In terms of the airway, we're not stopping anything in terms of chest compressions to put in an airway, right? That's your least definitive thing that you need to do in terms of resuscitation is provide them with a definitive airway. So whether it's your BVM and in OPA or not stopping chest compressions and putting in a combi tube or a King airway or something like that is perfectly adequate, but not interrupting CPR to put in an airway is your best chance the patient's going to have. In terms of volume stuff, so we didn't talk about this when we talked about respirations, but your adult bag is a 1 liter bag. So if you're squeezing this thing with both hands, you're probably giving them a tidal volume of somewhere around 700 to 800 milliliters of oxygen when you're ventilating them. So you can use a PD bag, which is 500, and squeeze it fully. You can use the adult bag and just don't squeeze it all the way. So you probably need half the volume in an adult bag, and in a smaller person, even less. Less is definitely more when it comes to ventilation in cardiac resuscitation. So respirations depends on the volume you're using again as well. So if you're using this big bag and you're squeezing hard, like somebody has to keep an eye on that, thinking about the amount of volume that you're delivering to the patient. This is why ventilators, I think, are helpful. So especially in your resuscitated arrest, I think ventilators are really helpful. And I know we used them the last time. So just something to think about when you're doing these resuscitations. Circulation, we're going to minimize the time off the chest 100% of the time. And hands-off defibrillation is going to be quick and simple anyway. So the machine is charged, you analyze the rhythm, you shock them, and you're back on the chest. Charge your defibrillator prior to rhythm analysis is a good way to save some time. Your end tidal CO2 is a good guide to how well you're doing your chest compressions. The cool stuff with refractory VFib, whether it's the simultaneous sequential defibrillator or treating them with a beta blocker like Esmolol, this is probably the first thing that I'm going to do. But at some point in time in my career, I hope to shock somebody twice at the same time. Vasopressors, again, probably more of an ICU level thing of where we're going to titrate that. Your mechanical CPR is definitely better than any of those thinking Lucas devices, unless we're in the cath lab, which most of these patients are going to go to at some point. And then post-arrest stuff, again, more for me. All right, let me go back to my screen here. Good. So that's really all I have for you. If you've got questions off of this, I didn't make this presentation to be, completely in line with all of what we do. But so just kind of take the why of behind the scenes of what we do is really what I was after here, and provide you with some of that background information. If you have questions, concerns, ideas, anything you want to talk about, certainly get that stuff off to Captain Pacheco, and I'll address it next month in our education. So thanks for spending the time with us, and we'll talk to you again next month.